The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. This is Lisa Myers with ARX Healthcare in Franklin, Tennessee. On behalf of the Tennessee chapter of HFMA, I want to thank you all for joining us today. We've posted the slides on our website for today's presentation. You can find that link in the GoToWebinar chat box. Have a few upcoming announcements to make. Registration will be open shortly for our next webinar, which is on March 14th. You can visit tnhfma.org/webinars for more information. The Tennessee HFMA chapter is hosting a Lunch and Learn session in Knoxville next week, February 23rd. David McMillan of PYA will present value-based reimbursement. What do you need to know to get there? The cost is only $20 and lunch is included. Please visit our website to register and for more information. Also, registration is still open for the Region 5 Dixie Institute that will be in beautiful Savannah, Georgia, March 21st through 24th. Please visit hfmadixie.org to register and for more details. We have our upcoming annual Kelly Miller Payer Summit that will be held across the state March 27th through 30th. Registration for that is now open as well, and you can visit our website, tnhfma.org, for more information and to register. For those of you who are obtaining CPE certificates today, you must be connected to the webinar for at least 90% of the duration, and you must respond to at least 2/3 of the polling questions. Today we have Michael Webdale, Jr. Mr. Webdale has calculated and projected area wage indices from annual CMS updates, trained wage index seminar participants, and provided assistance to hospitals filing appeals with the fiscal intermediaries and CMS. Mr. Webdale has served as the project manager of Occupational Mix Survey Program for numerous hospitals and hospital associations, analyzing hospitals' occupational mix and support data and preparing survey forms and support documentation packages. Mike, we are excited to have you, and I will turn it over to you at this point.
Well, thank you, Lisa. All right, let's get started, and we'll appreciate everybody taking the time to join us today, and let's go over the agenda of what I'm going to cover. So we're going to do a quick background of the occupational mix and the history of it. We're going to talk about the importance of it and the impact on the hospital's average hourly wages. We're going to talk about who has to participate in the survey and who has to fill out the survey. And then we're going to go over all the due dates and the time frame that you need to collect the information. And then we're going to talk about the categories for all the data input and what you need to do to gather the salary and all the contract labor information. We're going to run through how the occupational mix adjustment factor is calculated. And that's important because that gives you an understanding of how to make changes, or it gives you, this, if you change this number, this is how the occupational mix affects my hospital. So we're going to run through, the whole calculator that CMS has on their website. And then since the data is released in the public use file with the wage index data, it is available, and we can run our numbers, we can run your numbers with and without the occupational mix. So we've got those numbers for each CBSA with and without the occupational mix. And then finally, we'll cover strategies for completing it. So once we go through that calculator, then you'll be able to determine, okay, if I change this number, what's that going to do to my average hourly wage adjustment? So before we get started, Lisa, we've got the first poll question.
All right, so our first polling question, how many hours does CMS estimate that it takes to complete the occupational mix survey? 96, 240, 480, 576 hours, or none of the above? I'll give everyone just a few more seconds to vote on that. And just a reminder, if you are certifying for CPE certificates today, you'll need to answer 3/4 of the polling questions. I'm going to close that poll now and share the results. So Mike, it looks like 23% say 96, 13% say 240, 28% say 480, 8% 576, and 28% said none of the above.
Okay, if we go to the next slide then, and the correct answer is of 480 hours. The first paragraph here just talks about this is where the public law is that requires CMS to collect this data every 3 years. So if you wanted to go to that, you can. But in instructions, they do say that it takes 480 hours to complete. Now that includes, like I said, in the instructions there, to review the instructions, get data sources, collect all the data, review. So 12 weeks, that's a really long time. Is it really going to take that? Maybe it's not all your time because you're getting information from payroll, you're collecting information from contract labor. And also, you've just used an hour today, so now you've only got 479 more hours to go. So why is the occupational mix important? It's to control for the hospital employment choices on the wage index, and that's what CMS created it for. And again, in the second paragraph here, those choices are management decisions rather than differences in the geographical area of labor, because that's what the wage index is, the geographical differences. And then they just want to make sure that it's, so if you do decide to staff with RNs, hire more RNs, then your occupational mix adjustment is going to control that effect. And that was the purpose of it. That's what they accomplished. And so it's kind of counterintuitive that, okay, we're providing better care, we're going to get hurt with the occupational mix. But again, that was their intent, because they're saying, okay, if you staff with more RNs, your average hourly wage is higher, and it's a choice that you're making and not something that's based on the geographical area that you're in. So markets with an expensive mix of employees and contract labor have the average hourly wage go down. And then the inverse is true, that if you've got lower than the national rate of RNs, then your average hourly wage will be increased. So the most important factor is the RN hours to total nursing hours. The national percent in the last survey was 71.5%. That was the kind of break-even point. And again, it's based on the hours, so we're going to cover that too when we go through our calculator. So if the RN hours to total nursing hours was greater than 71.5%, your occupational mix factor was negative, and if it was below that, then it was positive. So why is it needed? It does impact each hospital's average hourly wage, and so that's the importance of it, and it's going to be applied to your reimbursement for 2019, 2020, and 2021. So that's the last survey will be affecting your reimbursement beginning, the last year will be this October 1st, 2017, and then this survey form will be used for the next 3 years. So you want to make sure that when you're filing it this year, we're going to file it, we'll go over the deadlines here, and then you want to make sure that it's going to go through audit, and some audits are more intense than others, but you want to get it correct and you want to get it maximized, because it affects, again, your individual hospital, which is then pooled into the CBSA, and it also is going to affect your reimbursement for 3 years. So that's why it's important to get it correct and maximized. So what has been the effect of the occupational mix? So small and rural hospitals who CMS was trying to help, they sometimes have to staff with a certain number of RNs, and they may not be able to be as efficient with the other categories. So they often get a negative occupational mix because of that higher percentage of RNs. And then, like I said, CMS was trying to help the small and rural hospitals and ended up hurting them. So in 2006, when they switched to this new methodology, they tried to do a partial implementation. And they were sued and they lost. And so in 2006, if you were filling out this survey, you did a 3-month survey. CMS kind of looked at the results. They didn't like it. They said, we're going to partially implement it. They lost. You had to then, CMS said, well, we don't have enough reliable information, so we need to do another 3-month collection. So that year, a couple cycles ago, you would have had to do it for 2 3-month periods. So who has to participate and who has to fill out the survey? So any hospital that's subject to the IPPS, the Inpatient Prospective Payment System. So obviously critical access hospitals do not have to fill that out. or anyone that became a critical access before January 1st of 2016. So the participation rate, that nationally it's 94% of the hospitals who were required to fill out the survey did, and then in Tennessee it was a little higher than that, 96%. So they don't have any penalty for non-response, and they haven't in the past, and they haven't proposed one yet. They've left it open in all the Federal Registers. They keep saying they're reserving the right to apply a penalty in the future. So since there is no penalty in a hospital that doesn't respond to it, those are normally very small, either salaried hospitals or hospitals with very little Medicare discharges. So if the hospital doesn't respond, then what they get is the average occupational mix adjustment for that CBSA. Now it is an adjustment to each individual hospital, but again, they run the numbers and they can tell, okay, this CBSA's impact was this number, so then they apply that to the non-participating, the non-filing hospitals. So let's go over the dates. So the first important date is it's due July 1st, and it's going to be applied again October 1st of 2018. That gives them time to collect the data, do their audits, publish it, and then there's going to be revision opportunities. They haven't kind of put that out there yet. But July 1st due date is a Saturday. So most likely they're going to move that to July 3rd, which is the Monday. I don't know that they would submit it, do it before the June 30th on Friday, but it has to be to them. And it has to be submitted on the Excel form that CMS provides. And it can be downloaded from CMS's website, and it's where they have salaries and hours across horizontally. So it's a little tough to read, but when you are entering the numbers, if something isn't flowing right, or it doesn't it doesn't make sense, or it's not passing one of the audit things, you'll get an error message. And they want this emailed, so again, it has to be to them by the July 1st, so they may be reissuing the instructions with an updated date. Some more of the other dates. The last survey, the last survey was conducted with the 2013 data calendar year, and it had to be submitted in July of 2014. And if, again, the last survey impacts your reimbursement beginning 10/1/2017. So for this survey, it's calendar year 2016 data. So it's for pay periods ending between January 1st and December 31st. They're looking for 26 pay periods without any accruals or any other adjustments. And so you're just doing a matching of the salaries and the hours for the pay periods that are occurring in the calendar year 2016. And we've got it here again. It's due July 1st, 2017, again, due to them on that date. So before we get into the categories, we have a second poll question about the categories. So if we want to run that, Lisa.
All right. Which occupational category is not included in the survey? Surgical technologists, interns, registered nurses, medical assistants, or none of the above? And again, just a reminder for those who are seeking CPE certificates, 2/3 of the polling questions today have to be answered. In order to receive that, we have about 96% voted, so I'm going to go ahead and close that poll. Share the results. %7 say surgical technologists, 69% say interns, 2% say registered nurses, 0% say medical assistants, and 22% say none of the above.
And that's because most people got it correct. It is the interns and residents that are not included. So the categories are coming from the Bureau of Labor Statistics employee categories. And you need to include employees directly hired or acquired under contract for the RNs, LPNs, and surgical technologists, nursing assistants and orderlies, and that's changed from the last survey. It used to be medical aids and assistants. I think maybe the BLS definitions changed, and then medical assistants, and then the all other occupations. So when we're doing our surveys, when we're doing analysis for hospitals, this is the format we like to use because it gives us a comparison of obviously salaries and hours to get the average hourly wage, and does the average hourly wage make sense? And then do the percentages make sense of how the RNs compare to the nursing total? So that's why we've got those two categories of hours highlighted for the RNs and total nursing. That's the determining factor of that 71.5% from the last survey data. Obviously we don't have the 2016 data yet because it hasn't been submitted, but that 71, 72, that ratio of RNs to total nursing has kind of stayed consistent over each of the different years of the survey forms. Obviously the average hourly wages are going up because if you've got a cost of living increase of 3% each year, then obviously the average hourly wages are going up. But if you don't have a change in the mix of your of the employees or a change in the services you provide, then those salaries or the hours should kind of stay consistent. So that's this is good analysis again for looking at the 2016 data and then also comparing it to the 2013 data and say, did we really have a big swing in this category in one area or another? So the cost centers that you need to use, these are the 18 cost centers that are used for the occupational mix categories for all the nursing. So CMS chose these because these are where most of the nursing occurs in the hospital. And so this is, obviously the cost centers from worksheet A. And so when you're collecting the data, what do you need to do here? So when you're gathering the data, you need to look at the salaries. So it's your regular overtime, all of those different categories, all the PTO salaries, and then you need to have the matching hours to those salaries. So all those categories. For overtime, anyone paid at time and a half should only be recorded as 1 hour. Employees that are paid a salary and work 40 hours per week, then you use the 2,080 hours. If there's a non-paid lunch period where they're there for 40 hours, they're only working 37 and a half, or only getting paid for the 37 and a half hours, well then you would use the 1,950 hours. No hours again are required for bonus pay. And so our rule of thumb that we use for the salaries and the hours is use the same information that you use for your wage index. When you're preparing your S3 Part 2, if you exclude the hours for that, then exclude the hours for this. The on-call hours, have been an issue. They're not allowing that for contract labor. So then you wouldn't be doing that. You wouldn't be using any on-call hours for this occupational mix survey either. So then who do you need to get involved? So obviously you're going to need to get payroll involved because you're collecting the salaries and the hours, again, for 2016. So if your fiscal year is a June or September, for this you need to use calendar year 2016 data. So the payroll person is going to be involved to get those dollars and hours. Then you may need to look at the chief nursing officer and similarly the human resources to look at responsibilities. And first off, are they doing patient care? And then if not, then it goes into the all other category. But then you need to look at the definitions in the instructions. And we'll go through that later, but you may need to get these people involved because you may have, you may be able to reclassify something from an RN to down to the other, over to all other, or something from all other to one of the other categories to dilute the RN ratio. So the RNs around the country, what we did is we downloaded BLS data and just got the average hourly wage for each state. California has the highest at 101,000 per year. Iowa had the lowest at 55,000, and Tennessee is right, at 57,000 per year. So this is, when we go through audits with hospitals with the occupational mix survey, a lot of times the question is, why is the average hourly wage for this category so high? You could use something like this. You could use BLS numbers to say, okay, well, this is what we're paying. Or we've got more contracted RNs than salaried RNs, so it makes sense that our RN ratio is higher than the state average for our area. And so then before we get into the contract labor, we've got our third poll question.
Get that pulled up for you. So polling question number 3. Did you complete the last occupational mix survey in 2011? Yes, I led the effort at my hospital. Yes, I participated but did not lead the effort. No, I did not participate in the prior survey. Not in my area of responsibility, or none of the above.
And it is 2014, but
all right, I'm going to close that polling question and share the results. 20% say yes, they led the effort at their hospital. 17% participated but did not lead the effort. 24% did not participate in the prior survey. 30% say it's not in their area of responsibility, and 9% none of the above.
Well, again, we do appreciate everyone taking the time to fill this out, or to attend the survey here, attend the webinar, and it's good information to have, whether or not you participate, whether you're filling it out or not. You may be involved at some point, in it. So let's get into. So we've covered salaries and hours. Let's cover contract labor. So again, you're going to include all the contract labor that's included on your worksheet S3 Part 2. So your line 11, direct patient care. If you've got any RNs that you're contracting out, that's most likely where they are. So those are going to be included. You've got your those other contracted administrative and general, dietary, and housekeeping. Those lines are not one of the 18 cost centers, so then those contract amounts would belong in the all other category. And then you want to use the amounts that were paid in calendar year 2016. So it's like a cash basis recording. So what is not included? So you got the employees that are in excluded areas from the IPPS. So you got your SNF, psych, and rehab, and those are the lines on the worksheet S3 Part 2. You've got all your Part A teaching, your Part B, and your CRNAs, and those are the lines on the S3 Part 2 again, and then the interns and residents. So these people are not included at all in the survey form, not in the nursing categories, not even if you have nurses in the psych or rehab. They're not in the RN categories, they're not in the nursing categories, and they're not in the all other category. So you may need to do a reconciliation when you say, okay, here's the total salaries from the hospital, here's all the contract labor that we're adding in. Now we're removing all of the excluded units, all of our teaching in Part B, and then you're going to come up with a total that's going to be reported on the occupational mix survey, and then you're going to split that out between the nursing categories and the all other categories. And now here is where you can download CMS's calculator, and you have to go through it's the prior survey, so you have to go to the fiscal year 2016 data to get the calculator. They'll be updating it, with the current data, but it's just based on that information. So here is what the calculator looks like. Okay, there it is. And the fields in pink in the middle there are what you have to fill in. So those are it's hours first and then salaries. The fields in green are the ones that come from the data. So this is coming from the last survey form, these average hourly wages. So again, these will be going up, based on just the cost of living increases that have occurred. And then the fields in blue are going to be, okay, there it is. Fields in blue are the ones that are calculated. So when you're looking at the calculator form, there's actually two tabs. The first tab is your average hourly wage information from your S3 Part 2. The second tab is your occupational mix survey information that you fill in. And then since the adjustment is to each individual hospital's salaries, it affects your average hourly wage, and they need that information. So now here are the steps that are taken. So and then we'll run through actual numbers. So you determine the percentage of each nursing category by hours. You multiply that subcategory percentage by the national average hourly wage. That determines an average hourly wage by each nursing subcategory. Step 4 is you subtotal that. Step 5, comparing that hospital average hourly wage to the national. Step 6, calculates your occupational mix factor. Now so that's the number that comes out, but that's then impacted by your salaries. So the nursing salaries then come into play. The hours determine the percentages. The salaries determine what that impact is. So that is multiplied by the nursing percentage. That is added to the all other category percentage, and then you come up with the impact on your hospital's average hourly wages. So we filled in some numbers here, and this is going to be a positive average. So the first step is determine the percentages. And again, it's based on hours, and that's how the calculator has it, with the hours first before the salaries. So this hospital's, they have a 67.92% RN hours to total nursing hours. So it should be positive. So then you multiply it. Step 2, you multiply it by the national average hourly wages. Step 3 is you come up, that comes up with a category average hourly wage. Step 4 at the bottom there, it comes out to $30.64. So then you compare that to the national of $31.85. Okay. And then step 6 is it comes up with your occupational mix number of 1.0393. So if that was the final number, then your average hourly wage would go up by 3.93%, but the salaries come into play. And the salaries for this hospital are the 47.74%. So that 3.9% increase only affects 47% of the salaries. All other is 52%. And so when you pull in the average hourly wage information from the first tab, then the average hourly wage goes from $46.85 to $47.73, which is a 1.9% increase in the average hourly wage. And so that is the importance of the dollars and the hours. When you're running the calculator, you can look at the information and say, okay, we know we're positive because our RN ratio is below 70% in that range. We want to make sure that everything, the all other category doesn't have any excluded units in it. You want to make sure, you're trying to, you obviously need to get it correct, but you want to be able to maximize it. So if you have a negative occupational mix adjustment because you have a high RN ratio, then you want to make sure that you're including everything in the all other category that you can. You also want to make sure that that something is not being reported in the all other that belongs in the medical assistants or the nursing assistants and orderlies. So we've also got an example here of just a negative. And we're not going to run through all the steps. We just filled in the numbers here. So the RN ratio for this one is 84%. So when you run through the numbers, you go through to step 6. There it's 0.9120. So that's an 8.8 reduction. But again, this hospital only had 32% of their salaries in nursing. So then you multiply the numbers, you come up to a 2.9% decrease in this hospital's average hourly wage. So how significant is an impact on the wage index? So the largest impact occurs in CBSAs where there are very few hospitals. That makes sense. So in San Luis Obispo in California, when we run the numbers, they had a 6.4% decrease in their average hourly wage due to the occupational mix survey. And there's only 3 hospitals in that CBSA. And then for Lebanon, Pennsylvania, they had a 14% increase in their average hourly wage due to the occupational mix survey, and they only have 1 hospital. For that California hospital, that California CBSA, they're one of the highest in the country. They do have, in California, they do have mandatory contracted, the nurses have to be, the RNs have to be contracted, so that's why they have a high ratio. So their wage index is high, that's one of the reasons that their wage index is high, but the occupational mix is bringing that down 6.4%. So now the hospitals in Tennessee here. So these numbers, the first column there is the wage index without the occupational mix. The second one is the occupational mix adjustment, and the third is the final number that you had for this year. If you're getting the rural, even that middle column is still a true number. What we did for that occupational mix adjustment is we looked at just the pure hospitals before any reclassifications or rural floor budget neutrality numbers. And so that's the impact that the hospitals have. They may not get reimbursed on that, but that's just if they were getting their pure numbers, that's what it would be. And an interesting thing about the ACA is that it's changed the rural floor budget neutrality to a national funding. So it used to be, it was national funded prior, and then at some point CMS was starting to fund that within each state. So if the ACA is reversed or repealed or changed, are they going to piecemeal parts of it back, or are they just going to take it all out? We don't know. But if it is just gotten rid of, then the funding, which is national for which no CBSA can be below the rural of that state, that's funded nationally. It would go back to being funded within each state. So states that have CBSAs with the rural would be hurt by that. And there are some states that don't have any funding, so they're funding all the other states. The biggest ones being hurt would be California and Massachusetts, because they have a lot of CBSAs and hospitals getting the rural rate of those states. And so let's do the last poll question before we get into the strategies for optimizing your occupational mix.
Before I launch that polling question, Dave, just wanted to let everyone know we had some technical difficulties with getting the slides loaded on the website, and the presentation slides are now available on our website for download. And again, you can find that link in the chat box. So for our final polling question, strategies for optimizing the occupational mix adjustment include only RNs involved in patient care, scrutinize functions of LPNs, etc., look at others who may do work of the LPNs, etc., or all of the above. And again, just a reminder for those who are looking for CPE certificates, 2/3 of the polling questions must be answered today. And it looks like we have 92% voted. So give everyone just a few more seconds. And I'm going to close that polling question and share the results with you, Mike.
Okay.
6% say only RNs, 2% say scrutinize functions of LPNs, 6% look at others who may do the work of LPNs, and 85% say all of the above.
Yeah, that's correct. Whenever there's an all of the above, you should probably choose it. Those are all good strategies. So the first one is minimize your RN percent and maximize the other 3 nursing categories. Whatever you can do to do that, whether you're looking at the all other category and moving things up that do have the responsibilities of the LPNs or medical assistants, or if you've got RNs in an excluded unit, make sure that they're not in that RN category. It is your RN hours, the total nursing hours nationally, that's going to determine that. That's the determining factor of whether or not it's going to be positive or negative. So if you're above the national average, you get a negative, and it's below that, you get a positive. So the national average in the last survey was 71.5%. We don't expect that to change much. So then you need to look at job titles, and you're asking yourself, are they involved in patient care? That's the first thing. Only those involved in patient care need to be involved. Anyone performing administrative functions then goes into the all other category. So you need to look for RNs on the floor that are doing administrative or educational functions, and those need to be moved to that all other category, because it's just the direct patient care that's included in the nursing categories. Then you need to look at the LPNs, the nursing aides, orderlies, and you need to be able to, if they have those job responsibilities from the instructions, that they need to be included in those nursing categories. So you need to look at other departments where someone may be doing a responsibility and not categorized as a medical nursing aide or a nursing assistant or the orderlies. So if anyone is handling those responsibilities, they need to be moved into that category. And so one of the examples are patient transport. And so if they're doing that and they're not in the nursing assistant category or the surgical technologist or LPN, then where are they being reported? And if they meet those responsibilities, they can be put into that category, as long as they're in one of the 18 cost centers. And so that's, if you've got non-excluded clinics, you've got hospitals may make choices to bring clinics into the hospital so they can get the Part B reimbursement. Well, for wage index, you're bringing those positions on. Those Part B positions are not included, whether they're contracted or salaried. So they're being removed. When they're contracted, the clinics have all of those personnel on their payroll, so they're not on the hospital payroll. When you're bringing those clinics in-house, then you're having all that support staff, and that's then lowering your wage index because you're bringing all these lower paid support staff. So if you do have those clinics in-house, then you want to make sure that all the staff, all the support staff is being included, and if they're doing any of these responsibilities, that those are being included as well on the occupational mix survey. So when you have the director of nursing or anyone handling those functions while the director of nursing isn't there, that goes into the all other category. If you have someone who's splitting their time, then you can do a split. You don't need time studies necessarily to do the split. If they're doing 50% administrative and 50% actual patient care, you can do that split to move that administrative portion down to the all other. Again, transportation for security, transportation for surgery, that goes in the LPNs or the surgical technologists per the instructions, and then the advanced practice nurses. Obviously, if they're billed under Part B, then they're removed from the wage index calculation, then they're also removed from the occupational mix survey as well. The instructions do say to include them in the all other if they're included on the S3, but we don't see that very often. So again, our rule of thumb is to include them. Whatever is on the S3 Part 2 for wage index, you do the same thing for the occupational mix survey. So what's next? So you need to plan ahead, and you need to look at who's preparing the form, who's going to sign that, and they need to collect then the payroll information for the 2016 calendar year. For contract labor, I didn't talk about this earlier, the hours are the big issue in your contract labor, just like they are for the wage index. If you're able to substantiate hours, then you can include those contract labor dollars. If you've got any home office costs that are on the hospital, then they're not in one of those 18 cost centers, then it goes into the all other category. Any related organizations need dollars and hours need to be reported. And again, it's due to CMS July 1st. Again, that will probably be changing, but since it's an Excel form and you're emailing it, it's due to them on that date. So we can open it up for any questions. We have my information and Dave's information here. You can, if you've got specific questions on your hospital's information that you want answered, you can give us a call directly. Otherwise, we can answer anything that's out there now.
At this time, if anyone has any questions, you can submit those in the chat box, and I can read them aloud so that Mike and the rest of our audience can hear them.
Yeah, this is Eric. Mike, I just wanted to do a point of clarification with the survey collection of 2016 data. That's regardless of your hospital's fiscal year end. So if you're a June year end, that we're still using the 2016 calendar year. So I didn't know if that might come up as a question, but just wanted to make that clarification.
Okay, thanks.
Mike, I have a question for you. If you have nurses who don't fit into one of the 18 cost center categories listed, how do you account for them?
So all of those nurses that aren't in those 18 cost centers belong in the all other category, even if they are RNs. So those, if they're not in the 18 cost centers, they go into all other. If they're an excluded unit, then they don't go on the form at all.
And Mike, you had talked about that reconciliation, kind of starting with the payroll data, and then adding in whatever contract labor you may have, or home office or something. But then you take out the excluded areas. Kind of the next step in that reconciliation is, okay, here is that remaining payroll, and then you say, okay, here's that remaining payroll for just those 18 cost centers. And all the other remaining cost centers would go into the all other, and then you kind of start doing your analysis of within those 18, where are my RNs, where are my surgical techs, that kind of analysis. So that's kind of, I think, one step in that reconciliation in preparing the survey forms.
Mike, we have another question. Does a long-term acute care newly certified file occupational mix?
A long-term care.
I believe the way it was meant to be posed is, does a long-term acute care that is newly certified need to file?
I guess if they were available, if they have information that's available in 2016, I believe they'd have to would have to fill out the survey form, because we're looking at 2016 data.
And I would just say to the respondent that submitted that question, Mike's information is available, so if you want to reach out to him individually, I'm sure he'd be happy to give you more clarification on that.
Okay, yeah, because if they're in the IPPS system, then they would need to. If not, they wouldn't need to.
Okay, we have another one that just came in. It says, we have nurse technician students who are within 2 semesters of graduation. Would they be considered RN since they do not have their license yet? They do the work of an RN.
If they don't have, I think the instructions say that licensing or registration is required. So until they are officially an RN, I don't think they're not in, they wouldn't be included in the RN category, because I believe that's in the instructions.
Yeah, this is Eric, and that's how I would categorize it as a, they're not an RN. So you start with kind of the basic definition of it. Yeah, they don't fit that criteria. License. Yeah,
they have the responsibilities, but it specifically mentions in their licensing or registration is required. So until they have that designation, they're not recorded there.
And so with just a clarification on that, so they would be then included in the all other, correct? Because we wouldn't want to report them in the LPNs or surgical techs because don't have that role, but I think they should be included in the all other. Is that how you would look at it, Mike, as well?
Yes, yeah, that they go into the all other category.
Yeah, okay, all right.
Great. Well, at this time, I don't see any other questions that have come through. Mike, we thank you so much for presenting to us today. And again, everyone, his website, or information is available here, and we have made sure that the links are available to the slides. Oh, we have one more question that came through, Mike. How does the final occupational mix adjusted AHW flow into the computed wage index factor of 0.7192?
Is that each individual hospital's average hourly wage is impacted either positively or negatively. So if all the hospitals in the CBSA have a positive occupational mix factor, then each individual hospital's average hourly wage is increased, and then that would increase the CBSA's average hourly wage, which would then increase the wage index. So it's an individual adjustment to each hospital's average hourly wage, and then when you look at the average hourly wage in the Federal Register, that's occupational mix adjusted. So it's changing each individual hospital's salaries.
Yeah, because each hospital gets adjusted their average hourly wage, then that flows up into the CBSA. So that increase that hospital received at their individual level gets reflected in that increase at the CBSA level, which then flows into when they calculate it based on it nationally.
So then that hospital's or that CBSA's average hourly wage with the occupational mix adjustment is compared to the national average hourly wage with all the national occupational mix adjustment, and that's how you come up with the wage index. I see the question there. It's the 45.51. How does that average hourly wage compare to the national 71.92 wage index? That means the national average hourly wage is higher than the 45.51. So you just divide the CBSA into the national, and that's how you come up with the 7192.
All right, Mike, it looks like we're getting some more questions coming in now, so everyone is getting more comfortable asking those. I have another one for you. We exclude CRNAs, but we have an assistant director of anesthesia. They are licensed and certified, but they have no direct patient care. They have no patient care. Director duties only. So would they be completely excluded from the report with the other CRNAs, or would they be included in other?
They'd be excluded. CRNAs are not anywhere on. They're not anywhere on the form, so it's just removed.
Yeah, because assuming they're reported on, what is it, line 6 of the S3, or line 5? I guess it would. I'd want to see where they reported on the S3. But if they're reported on that excluded line on the S3, then they would be excluded from the occupational mix survey form.
Any others, Lisa?
I haven't seen any come through yet. Give everyone another minute or so, see if we have any more questions.
And then Eric, who is at, Eric Webdale is also at RC Healthcare Management, so he's the other one kind of chiming in.
I didn't introduce myself. We were on mute for a while, so I couldn't talk.
All right, so at this point, I don't see any more questions, so we will go ahead and wrap it up there. Mike, we thank you so much. Eric, for your contributions as well. And at this point, we will end the webinar. Thank you, Mike.
All right, you're welcome. Bye.